the reason this all started, let me go back to the history. So this started in Canada. There's a gentleman who's now a friend and a colleague, Don WALANT. And Don was trying to get carpal tunnels, trigger fingers, smaller surgeries to the OR. And it would take a long time to get to the OR in Canada. So he started doing them in the office. And doing them in the office, like, oh, you can't do that. Matter of fact, I'll tell a story from 1983. We admitted carpal tunnel patients the night before on Sunday. Did their history and physicals, admitted them. They'd have surgery the next day. And then they almost stayed over the next night. So
really?
That was all that waste of time. That's years ago. So the premise of this whole thing is access. All right. So why can't you do a carpal tunnel in the office? Well, you need this equipment. No, you don't. You just need to have a dry field, and that's epinephrine, right? So you have an $8,000 deductible and go to a hospital to have a carpal tunnel done. That's a $5,000 procedure. That's ridiculous. I mean, why should you spend all that money when you don't need to because the resources aren't utilized? So you can do them in the office, under local. You can walk in. You can keep your clothes on. And I would go, if for people who are anxious, obviously they can either take a little Valium if they want to, or they can go to surgery and have an IV, go through the whole process and have a little bit of sedation.
What do you think the cost difference is between the two, if you had
Huge.
to guess?
$5,000 versus $400.
Oh.
Welcome to the Bone and Joint Playbook with Dr. John Urs, where we explore an extensive range of orthopedic topics and insights. Our goal is to help you understand the available orthopedic options and treatments available, and hopefully give you some answers to questions you might have. We want to thank our following sponsors.
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dorothy Lane Markets, Health Foods Unlimited, and Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup@stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
What have you been doing?
Well, playing a little baseball, finishing that up, and, the end of the summer is pretty hot, so everybody stays indoors and doesn't worry about work.
So before we introduce our guest here, who are you picking for World Series?
I'm going Toronto Blue Jays.
Especially after last night?
Well, no, I just think they've got good pitching and hitting. They probably won't win, but everybody's picking the Dodgers, and I don't want to pick them.
All right, well, you hear it right here. The baseball experts picking the Blue Jays. Do the Reds even stand a chance?
25% chance of getting in. According to AI this morning, 25% chance.
I'll take it.
Okay.
I will take anything you got. All right, so why don't you introduce our handsome and tall guest here?
Well, we're happy to have Brent Bamberger, DO. He's a hand and upper extremity surgeon. He is also, along with me, the two senior surgeons at Orthopedic Associates of Southwest Ohio. And he and I have been in practice together for over 35 years.
35 years.
And I'll just give you a little qualification of his background. He's obviously a fellowship-trained hand and upper extremity surgeon. He has special training in microsurgery, where we put little things back together with microscopes. He has a special interest in complex elbow problems. He's the program director of the orthopedic residency at Grandview Hospital in the Kettering Health Network. And we've both done numerous political projects with our academies and published numerous papers. So I think he's certainly well qualified to talk about the subject today, which will be wide awake, local anesthesia, no tourniquet.
You know, this sounds like it's something I absolutely will never want. I want to be put asleep.
Well, the word want is in the word.
What is it?
So WALANT, if you get rid of the two middle letters, the word want's in there. So we're going to use an acronym today, WALANT, and we'll tell Brent to tell everybody why they would want to know more about what is this type of anesthesia that we would offer people.
All right, he's set you up. So what is it about this anesthesia that I would want it? Why?
So the reason this all started, let me go back to the history. So this started in Canada. There's a gentleman who's now a friend and a colleague, Don Lalonde. And Don was trying to get carpal tunnels, trigger fingers, smaller surgeries to the OR. And it would take a long time to get to the OR in Canada. So he started doing them in the office. And doing them in the office, like, oh, you can't do that. Matter of fact, I'll tell a story from 1983, 83 and a half, maybe, something like that, where I came out to visit John at Grandview Hospital, and we admitted carpal tunnel patients the night before on Sunday. Did their history and physicals, admitted them. They'd have surgery the next day, and then they almost stayed over the next night. So that was all that waste of time. That's years ago. So the premise of this whole thing is access, all right? So why can't you do a carpal tunnel in the office? Well, you need this equipment. No, you don't. You just need to have a dry field, and that's epinephrine, right? So that's adrenaline.
Yeah.
All right. So epinephrine has always been looked at as, and we have a medical student sitting in the back here. We always have history of education that lags behind actual data. And what actually happens with epinephrine is, oh God, you can't put epinephrine in a finger, a toe, and a few other parts, right? You can't do that because it'll kill it. Well, if you look back at the original literature, it was procaine and epi. And it was acidic. It was like 2 pH. So it was like burning you as you put it in. That was the actual reason. So, some of the newer things, you can use epi. Epi will only last about 2 hours. I can put a finger back on. Well, actually, you can put
Finger
it on.
back on?
In about 12 hours. So you're only losing
with a microscope usually.
With a microscope. You're only losing 2 hours when you have epinephrine. So you can use epi. Finger's not going to die.
Really?
No.
You've seen them put the belt around someone's leg when they're bleeding in the war. Well, there's no blood flow to the leg that stops the bleeding, but they don't lose their leg over that, right? You're just like turning off the faucet. So there are times where the limb can have what's called ischemia or lack of flow without harm to the person if it's not too long. So you just can't do it indefinitely. But.
Can't do it for a couple of days, but you can do it for a short period of time.
So that's why if I cut my finger off, put it in ice, take it to you, and you're going to sew it back on?
Put compression on it, please.
That's a whole other topic of how you do it. You don't drown it. I mean, it doesn't do well drowned, but it does well cold. Actually, there's a story out of China where somebody left a finger out on the windowsill and it froze, and they put it back on 24 hours later. So there is things. The long answer to this is the wide awake local anesthetic no tourniquet is you don't need a tourniquet. Epinephrine will work. Now, when can you do it? You don't need to have, you don't need to drape the foot to take care of a hand. That's what we do in the OR. We drape the foot because I don't know, the bugs are going to crawl up there.
Drape means what?
It's
put it to sleep?
No, put a dressing over top of it. When you're in the operating room, they put all these towels on you and all this other stuff.
Oh, yeah.
You don't need all that. Right? You just need a small amount in that area with a numb finger, and you can take care of most problems.
So if I'm cut, my wife just had this done by you guys, by the way. She had carpal tunnel and the trigger finger. She put her hand on the table or something like that, or maybe you tied her down or something. I can't remember, but she remembered there was no pain.
Right.
She said she was wide awake for it.
Right.
And I said, I don't want that.
Well, I mean, it is interesting. That's a societal thing. It's absolutely a societal thing. The way I started it, which goes into some other topics, is we started doing this in Guatemala, so in 2013, 14, because you didn't have a lot of anesthesia. So we would do this all under local. So local with a little epi, so you don't need a tourniquet, so you don't need all these other processes. And then when we came back to the States, but a couple of years later, about 2015, 16, is where the insurance companies decided we're going to give everybody $8,000 deductible. So you have an $8,000 deductible and go to a hospital to have a carpal tunnel done. That's a $5,000 procedure. That's ridiculous. I mean, why should you spend all that money when you don't need to because the resources aren't utilized? So you can do them in the office, under local. You can walk in. You can keep your clothes on. And maybe you don't want to.
No, I want to take them off.
I'm glad. But I mean, you can keep your clothes on. You can eat. You can drive yourself. I mean, there's been plenty of things. It's simple things, and that's done. It started in Canada. It's really taking off the United States. COVID pushed it through the roof because you couldn't go to the hospital.
All right, so I'm lost in. So I'm coming in. You've tied my hand down. Are you giving me an injection? Am I taking a pill? What is this thing?
You're getting a little local shot right there.
Oh, and that's it.
20.
And how far does it go up or down?
It's about that far. So about 6 inches.
And how much?
So when your dentist works on your tooth, he numbs up that tooth, right?
Yeah.
He doesn't numb your whole mouth up.
Feels
But
like it
all
sometimes.
they need to do, well, sometimes it goes to the tooth next door, right?
Yeah.
Or the side of your lip. But you basically just need to be able to work on the part that's got the cavity in the tooth case or in your hand case. Dr. Bamberger is going to release your little ligament that's rubbing on your nerve, and that's going to open the drawbridge to make the nerve happy. Whatever he has to do to get it done, being able to see it, not have a lot of bleeding, and have you comfortable is the goal. And if you can avoid having a tube in your throat, maybe you should explain a little bit about why this is called a local, which means locally in the hand only,
Yeah.
versus a general anesthetic, which is the general patient is put to sleep or put under. And why, Brent, why wouldn't we want to be put under for a trigger finger surgery?
It's risk and benefit. All right. So you can be put under, you can have a tube put down your throat, but there's risk with that. I mean, some people have equated that to a concussion. So you can play in the NFL. So it's a CTE thing. When you have a general anesthetic, it's a huge hit on the brain. So that's one. Two is you can numb up the entire arm, right? Where you stick a needle up under somebody's arm or up in their neck.
Yeah.
But there's a lot of other important stuff up there, and if they hit the wrong thing, that's a problem. So all you need to do is just locally inject around where you're doing the surgery. And
Is it an anesthesiologist doing this, or are you doing this?
myself or my physician assistant. Yeah.
Really?
Yep.
And how long does it take to get numb?
It takes about 2 or 3 minutes to get numb. It takes 25 minutes for the epinephrine to work, so the adrenaline. So that's what shuts down the vessels.
Yeah.
So the vessels will react to epinephrine. So they're usually, like a garden hose. It just kind of flattens them out for a period of time, about 2 hours.
Wow.
Shuts them down.
So you're basically, you shoot me up, you're going off, you're doing something, you're coming back in. 25 minutes later, said,
Fix it.
fix it. Does it bleed? Am I losing blood during the surgery?
Minimal to none, because you have shut the vessels down from the epinephrine.
Wow.
So it's the same thing as you don't bleed to death when they go to the dentist and you yank out that tooth or fix this or fix that. I hate to go to the dentist because some people like the dentist and some people don't. Right. But so no offense to dentists, but I mean, some people like them, so they don't. But that's exactly it. All this stuff has been done with Wide Awake is because of dental. Dental's done all the work, all the regulations.
So that's Novocaine they give me when I'm a dentist.
Same type stuff.
It's the same type, same family?
Same family. It's called xylocaine. It's a next door neighbor.
Wow. Okay, that's fast. So can we talk a little bit about the surgery itself? Is that okay?
Mm-hmm. Yeah.
Yeah, I think there's a couple things. When surgeons decide you need a procedure, that is called patient selection. So who would be candidates for a procedure? Because sometimes we talked about trigger fingers, you can inject those with some steroids, and that may loosen them up for 6 to 12 months, but then maybe after repeated injections that they don't last as long. Then you've got that, or you've got some other issues like rheumatoid arthritis or other reasons. Those little pulleys, the little ropey structures that bend your fingers,
Right.
get stuck. And a triggering is kind of what that was alluded to in one of the other podcasts. But when you say, well, who is a candidate, then it's up to the surgeon to say, well, this is a mechanical problem. You're not going to really be able to move your finger unless I release the thing digging into that tendon.
Right.
So how do you pick patients that need the surgery, or what? Maybe someone who would not be a candidate for a wide awake anesthetic if they're very anxious, or maybe they have a bad heart and you want to monitor them at the hospital.
And I would go, if people are anxious, obviously they can either take a little Valium
Yeah.
if they want to, or they can go to surgery and have an IV, go through the whole process and have a little bit of sedation.
What do you think the cost difference is between the two, if you had to
Huge.
guess?
$5,000 versus $400.
Oh, wow.
Almost tenfold, probably, I'd say.
Yeah.
That's wild.
That's just for one case. Trigger fingers are interesting because that's basically it's a fishing pole with a fishing line. Somebody tied a knot in your fishing line, and it gets stuck in the eyelet. That's a trigger finger. So it gets stuck in there. So you inject steroid, like Dr. Urs had said, and you dissolve that knot. So it glides along usually it'll There's a lot of philosophies of what gets dissolved, but that'll do it. But if you can't, you cut one of the eyelets. If you cut one of the eyelets in a fishing pole, it won't heal back, but in the body it'll heal back, but it'll be wider. So that tendon, the fishing line, can ride through it.
And just so I know for the folks out there, where is it located? Right there?
Right there.
And where are you making my incision?
Right there.
So you're just going in right where it's at, small incision, prying it open. You have
Small,
magnifying
delicate
glass?
dissection, no prying. You dissect down, and then you just release that pull.
And you have obviously some type of magnifying glass because you're dealing
3.5, 4.5 magnifying glasses all the time.
Okay.
Like what the jewelers use.
Yeah,
exactly.
Little gemologists.
Yeah.
So and how long does this take?
The surgery itself about 3 or 4 minutes. The process about 35 minutes.
And so, I had a guitar player friend. I just saw him Friday night. He's coming to you guys, by the way. He had trigger finger, and now he's getting carpal tunnel syndrome. He has to go get carpal tunnel surgery, and he's a little bit worried about how that'll affect his guitar playing because
It'll make it better.
it'll make it hear that, Dan. And it's going to make it better for you.
Well,
But
it's just, those nerves are being pressed. His fingers are going numb, or they're sticking when he bends them. And having that improve should improve his hand function. When people ask us, are we able to get back to what we were doing? In most cases, you will. The difference is a knee replacement. You probably don't want to run and jump excessively on a fake joint, right? So, would you play pro football after a knee replacement? Probably not. There are limits to what people can do with a problem. But we talked about Tommy John surgery for elbows when people tear a ligament and they can't throw. Well, fixing that, they get back to throwing and they get back to their original velocity. So, there's a goal for most surgeons to try to keep people in the game. And they want to keep doing the things they're doing. And anybody can say, your family doctor can say, stop doing what you're doing and you'll be fine. It's like, well, yeah, but I really like playing the guitar. Like, well, let's find out why you can't.
So can we talk a little bit about carpal tunnel surgery?
Sure.
Where does that surgery take place?
Right there.
And same thing, you're small.
Local anesthetic, small incision, go for it. There are 20 ways of fixing carpal tunnel.
Really?
Different incisions, different little devices. Do it through the scope, do it through not through a scope. There's 1,000 ways. Bottom line is all you're doing is cutting the ligament on top. Right? There's skin, there's a small fascia on top of here. Fascia is basically the skin or the tissue that holds your skin to your bone so it doesn't pull off.
Yeah.
In the back of your hand, you don't have fascia, so it rides all over the place.
Okay.
So you cut through that fascia, find the ligament. Through that ligament is an arc of bone, and the tendons all run through there, and the nerve. The nerve's the flimsy piece of macaroni, and that's the thing that gets pushed on and loses from pressure.
And what are you doing when you're going in
You do the same thing as we talked about with the trigger finger.
Yeah.
You just release that ligament. Ligament opens up, nerve's a little happier, right? The ligament heals back, but it heals back larger. So there's a larger canal.
Like that drawbridge
Exactly.
analogy, just making an opening where a tight band was constricting. Think of the carpal tunnel, ropey tendons and nerve as little boats going underneath a bridge, and now you open up the drawbridge and everybody can stand up and a little more room in the boat. So there's room in the area where the nerves go through that little tunnel, and those are things that are addressed in the office by your doctor examining you, saying, yes, the nerve that goes to these fingers is the one that's involved. There are other nerves to other parts of your hand, so we want to be sure your diagnosis is right. You sometimes might have a nerve test called an EMG. Those are all up to the doctors who do your procedure to tell you what you can do for it ahead of time, with or without surgery. And we all try to get things better without surgery if we can. How do you think the feedback is, Brent, from patients who have had this? Like you now have put Aunt Betty through this local procedure, and she's like, that was terrifying, I hate it, or are they pretty good with it?
So most people, not most, probably 90 some odd percent love it, won't do it any other way. Self-referral. I mean, a lot of people are like, I want to do it here, I want to do it in the office. Right? And in certain insurances may not approve that, but I want to go into that. But they want to do it in the office. I mean, because they can drive in themselves. They don't inconvenience so the grandmother doesn't inconvenience the grandchild to bring them in. It's a simple deal. The most difficult thing they have to do is pick the music.
Pick the music?
Yeah, they're wide awake, so they pick the music.
And you have little headphones for them or something?
No, just
We'll
play Google.
We'll listen to anything they play for a while.
Yeah.
Really?
I won't say my. There's certain things I don't like to listen to. But
Oh, go
that's
ahead.
okay.
I do want to know, as a musician, what is it?
ABC. So I'm not a big country person.
I'm not a big country person either.
That's all right.
Sorry,
It's not
folks.
bad. I don't want to say it in front of everybody else, but it's all right.
I always tell them I don't operate too well to that.
It's exactly what I say.
What do you like, Doc? That's a great question.
It's exactly what I say.
So how do I know if it's carpal tunnel or if it's something else?
All right, so switch on carpal tunnel. Numbness and tingling in these fingers wakes you up at night. Trouble driving a car. Trouble playing your guitar. Probably drums will do it too. Since we just heard that drums are the most important person of the band, I heard.
They are.
Yeah,
that is
that's
true.
what I heard. Recent show. But that's carpal tunnel. It's a pinched nerve that happens here. Sometimes you can get better with a splint. Sometimes you can get better with an injection. Sometimes you need a surgery.
So what other procedures can we use the WALANT technique with?
Great question. Yeah.
So
besides the trigger finger
just
and
in
the
the
carpal
office, just to keep it simple, because you only use a certain amount of equipment, it's trigger fingers, it's carpal tunnel, it's little masses on fingers. Those are probably the easiest ones.
Like a little ganglion cyst or a bump.
Little bump here that you can
on
use.
the
Right.
tendon
Yeah.
or sometimes on the back of the wrist maybe.
But then when you move it into the hospital, just to have equipment, all tendon repairs I do under wide awake. So they're wide awake, they're numbed, there's no tourniquet. Once we're fixed, they can bend and straighten their fingers.
Yeah.
And those tendons work through the same pulley system that we talked about, like with a fishing pole.
Right.
So if you bunch it up too much, it ain't going through there, right? So you got to make sure you don't bunch it too much, or you need to, vent things so things will roll. So we do I do almost all under wide awake. So
Really, all your surgeries are at wide awake. By the way, how many
For
do you do?
flectitens.
How many do you do a week, roughly, if you had to guess?
30 or 40.
Really?
I do 4 to 5 in the office every day.
Well, and how many hips do you do? Because you have to go into a.
Hips are a little bigger surgery.
It's a little bigger surgery.
About 3 or 4 at the most. I mean,
Yeah, it's a little different story.
A day or a week?
a day.
A day. And you'll operate 3 days out of the week or something like that, 2 days out of the week. Okay. It's fascinating. So I hate to ask you
You
which.
will be put to sleep for most of those, although we talked about
so.
having your legs put to sleep, and that's called a spinal. So we did a podcast on having your legs put to sleep. That's
Right.
a type of what's called regional anesthesia. We didn't really talk about regions, but he alluded to the arm being asleep. That's an arm region, as opposed to just a local in the hand.
Yeah.
A general is the person's asleep. You're getting LALA medicine through the IV. They may or may not put a tube in your throat to control your airway, and that's usually based on how long the procedure is, who your anesthesiologist is, the nature of the severity of the illness and procedure, and the comorbidities, which are the other issues the patient may have. They've got bad, like lungs from asthma, or they have a heart issue, or some things they want to have better, like a short, narrow jaw, or a tight, big neck like a linebacker. So there are reasons your team will adapt what they do for your case based on the specifics of the patient.
So since we will acknowledge that we have a guest in this podcast sitting over there who's a med student, correct? And if you
His
had
name's Antonio. We can say that.
Antonio, I didn't want to give away your name, but if you had a son or a daughter who's going to go in orthopedics, what specialty should they focus on? Where do you think the future is in orthopedics? Is it in knees? Is it in hips? Is it just everything it is today, or is that changing? Because
I think it's everything is today, because people do stupid stuff. I mean, it's very simple. Knees and hips have gotten better. Actually, maybe they haven't. But when they started doing total knees and total hips, there's a technology that's being there. They're lasting longer, but people are living longer. So they're breaking on top of those.
Yeah.
They're in car accidents. They're twisting and falling. They're putting their hands in the wrong places. Orthopedics is going to be a good field no matter what. The difficulty will be paying for it, and I don't want to get into that. The bottom line is the people that are getting knees and hips and all these other things are over 65.
yeah,
That means it's all Medicare paying for it.
Correct.
It used to be, the margins used to be much better, and the margins are only in the people less from 65 to 35, right? So you're using that money to pay for us.
so you're saying the private insurance companies are funding
Yes.
the operations that Medicare is not going to cover because they've locked you down.
Or
into
the costs are too high.
Okay. But they won't refuse you, will they?
No, they're not going to refuse it, but that's just the way they have to work their margins because they're not going to make it. It's a money thing. So that's the thing that's coming down in the future. We are, as a nation, we are less healthy.
Yeah.
By a couple of years.
Sure.
But our lifespan's longer. So we're very good at chronic disease. We're very good at chronic disease. So those chronic disease people will have problems. And those chronic disease will have problems when they have their hip done by John or they have their knee done, but then they break in between. And that's going to, cost some money to fix that.
So
there's a lot of different things. We're getting away from wide awake, aren't we?
Yeah, we are getting away from wide awake.
That's all right. That's
My
okay.
last question for you on this podcast, and I'll let you wrap this one up. But I've been into the operating room with Dr. Ciccarelli where we did robotic surgery.
Right.
And we covered a lot of that. Mm-hmm. Is robotic surgery coming down the path for things like this that we just talked about?
It's not. There is actually a robot for microsurgery. So I was talking about putting fingers back on and using, human hair essentially sized to.
Are you saying I don't have any hair? Is that what you're going in for?
Well, I was going for human, but I mean, human hair. It's that thin.
Yeah.
To fix it. There are some robots that are starting to go there. There are not robots that I'm aware of to fix other things around the wrist. They're starting in shoulders. Elbows are not common enough. So it's getting there. It'll come. I mean, you need, as we alluded a little bit of AR, a little bit of mixed reality, a little bit of, robots as we move forward. It only makes sense.
Okay.
To get more data.
So I know we're going to keep him for another episode, and we're going to talk about his mission work, correct?
Yeah, we'll do overseas medical
I think that's pretty
services.
fascinating.
And this will segue into that because
Very much so.
that anesthetic technique is even more important when there's less, facilities and, resources in foreign countries like, Central and South America, Africa, and parts of Asia. So we'll get that, and if you're tuned to the Bone and Joint Playbook, look for that episode coming up.
So is there anything we left off about talking about the walnut procedure, where things are, people are awake?
No, it's just an easy way of doing it, and people. I mean, your initial reaction is what people do. Oh my God! Oh my God!
I don't want to be awake.
Oh my God! Oh my God! Well, you're part of the process. There are people that love to watch the YouTube the night before they do the surgery.
Oh, absolutely not.
And to see there's different personalities, and you don't have to watch. And as a patient I did today in our office, my comment usually is to the husband, is like, I've never lost a patient, but I've lost loved ones. I've had loved ones bang their heads on the walls because they worry that somebody's getting a cut on their hand, but the patients are not a problem.
Well, all right, so let's go ahead. We'll wrap this version of the Bone and Joint Playbook.
Let's thank our sponsors.
Oh, thank you for reminding me.
I've got to thank Ted's Salad Dressing, the Greek salad dressing, tedsaladressing.com.
It's fantastic.
GWR Group, the financial wizards over at Stiefel Financial, and we appreciate their sponsorship.
We absolutely do.
And be sure to like us on any social media platform you utilize.
Look at you. You're getting really good at this whole thing, aren't you?
I've got a great producer. Tri-level recordings. Here, Siri.
All right, folks, thank you very much for joining us. We'll be back again with another episode. We're going to talk about missions here in just a few minutes. Thanks.